time, we've got grand rounds that Mirna Ayache will do. This is a theme that she has, and we see if we can look at how she did this and what did she look at in terms of level 4 sleep studies. So Mirna, why don't you start off then? Thank you.
Sure, thank you. So thank you for having me back. For those who do not know me, I was a sleep fellow from 2017, 2018. So I'm a product of this program. So I'm happy to come back and do a grand rounds. This is a special interest of me, and I did some research with Dr. Stroll during my pulmonary and sleep fellowship in this particular topic. I apologize for the title. It was a mistake. It's level 4 sleep study, which is the pulse oximetry, and we'll go over that a little bit more in detail. So I'm going to talk about overnight pulse oximetry as a screening tool for obstructive sleep apnea or sleep apnea in general. We're going to talk about it a little bit in cardiopulmonary disease and oxygen therapy prescription. We're gonna look at how using a specific template can improve inter-rater variability in interpretation of the overnight pulse oximetry, and we're gonna have a glimpse into the diagnostic accuracy of other portable monitors, sleep portable monitors. So just as a reminder, so AASM classifies the sleep studies as 4 levels. And level 1 is the in-lab attended standard PSG, the one with at least 7 parameters: EEG, EOG, chin EMG, effort, oxygen saturation and airflow, and EKG or heart rate. Level 2 is something that we don't use as much. It's pretty much a comprehensive study that has also a minimum of 7 parameters, including, EEG, EOG. However, it's done at home, not attended, so we don't use that as often at level 2. Level 3 is the portable sleep study that we order, the home sleep study, and you have to have a minimum of 4 parameters, including ventilation, 2-channel respiratory movements and airflow, and oxygen saturation and heart rate. So level 4 is pretty much the simplest sleep study that you could get. And it only requires a minimum of 1 parameter. So you can have just an oximetry by itself with an EKG, or you can have an airflow channel, and that's classified as level 4. And we want to see here, so what can we get out of a level 4 sleep study, and how can we use its parameters to help us diagnose sleep apnea, or use it in other ways also. So just basic oximetry is based on the ability to differentiate 2 forms of hemoglobin, the oxygenated hemoglobin and the deoxygenated hemoglobin, and is based on the absorption of light of different wavelengths. So the oxygenated hemoglobin absorbs light in the red spectrum, and the deoxygenated hemoglobin absorbs light in the near infrared spectrum. And so when we shine the light on the hemoglobin, the concentration of the oxygenated hemoglobin to the ratio of the concentration of oxygenated hemoglobin to reduced hemoglobin will be proportional to the transmission of each wavelength. So this is the physiologic concept that the oximetry is based upon. So the pulse oximetry that we use in the intensive care unit or on the floor may not have the capability of detecting, for example, obstructive sleep apnea. And the reason it might not be a high resolution pulse oximetry. So it can generate an average of oxygen saturation over, for example, 4 seconds or longer. So it will not detect a drop in oxygen saturation that is brief and transient, that what we see in obstructive sleep apnea. When we do an overnight pulse oximetry as a sleep study, we should be using a high resolution pulse oximetry, and it will average the saturation over 1 or 2-second signal. And that will allow for better detection of oxygen saturation. So when we are looking at overnight pulse oximetry, or when we're purchasing one for our use, we have to definitely look at the averaging time of the saturation signal to look and see how accurate and how much is able to provide with high resolution. For example, this is a 30-second time interval, and you can see every 2 seconds you can record an oxygen saturation, and that is an example of a high resolution pulse oximetry waveform. So this is an example of an overnight pulse oximetry that you can just get handed to and asked, and you can be asked, so what do you think? Does this patient have obstructive sleep apnea? What does this patient have? And the problem with it is there's just so many parameters here, events, time in events, for example, average event duration, there is the index, there is the basal saturation, time spent with saturation as 88%. So the question is, what the evidence do we have of these parameters actually helping in detecting obstructive sleep apnea? And what should we rely on mainly? So for sleep apnea, and again, we cannot differentiate between obstructive or central sleep apnea on overnight pulse oximetry, but there are parameters that will suggest that this is sleep apnea. Indeed. And the first thing we need to look at is oxygen desaturation index. And it's just here, for example, this is from the VA, actually, an overnight pulse oximetry. For example, it's 5.3. And the second thing we need to look at is the waveform. So the two things that you want to look at when you're looking for the evidence of sleep apnea and overnight pulse oximetry are the oxygen desaturation index and the saturation waveform. So what evidence do we have that this is actually does reflect sleep apnea and does predict sleep apnea? So if we're looking for it as perhaps a screening tool for sleep apnea, and I'm not saying that we should use overnight pulse oximetry as a screening tool. This is, some people think that it's very useless actually. And one of the reasons is because you can get a PSG, which is basically harmless. And so that has higher accuracy. And the question is, why would you get an overnight pulse oximetry if you can get a sleep study? I compare an overnight pulse oximetry, for example, to a stress test, and then getting a stress test as a screening tool, and then getting a cath. But the difference is the cath is invasive, and so it makes perfect sense to start with a stress test. But since both overnight pulse oximetry and a sleep study are pretty non-invasive and pretty easy to use, so some people may think, why even bother with the overnight pulse oximetry? However, there are situations where you cannot get a sleep study. For example, inpatient, sometimes patient going for surgery, they wanted to look to see if they have significant sleep apnea. For example, patients with atrial fibrillation, they wanted to see if there is significant sleep apnea. There are certain populations that you might want to look, and it will be very expensive to order PIGs on all of them. So you can consider doing an overnight pulse oximetry on those patients. But say someone hands you an overnight pulse oximetry, you didn't really ask for it, and asked you, what do you think, does this patient have sleep apnea? We should be able to figure out what can we say, and how much do we think we're confident whether this patient has sleep apnea or not. So this is, for example, a study that was done. This is in one of the old studies in 1991 published in CHEST. They just looked at 40 patients, and they underwent both an in-lab PHG and an overnight pulse oximetry. And they looked at the waveform. This is for the waveform. And they defined a waveform that's positive, where you have a pretty obvious oxygen saturation and desaturation, and a pretty obvious positive for sleep apnea. And then you had the indeterminate, where you have ups and downs, but it's not clear, and the negative, which is pretty flat. And they defined sleep apnea here as apnea index of more than 10. And 15 out of 15 who had a positive waveform actually had sleep apnea. So if your waveform shows sleep apnea, this patient probably does have sleep apnea. Even the indeterminate one had sleep apnea, and even some of the negative ones also had sleep apnea. So that doesn't go very well for screening because it tells you that if you find it, it's there, but if you don't find it, it might still be there as well. Does not look like, a good screening tool, but it is something that you could use to determine what is the likelihood of having sleep apnea or not. This is one of the overnight pulse oximetries I was reading last week, and I just took this waveform here. Any of the fellows would like to describe to see what they're seeing and what do you think this patient has, just based on the waveform? Zach, are you there?
Yes, I am here. So let me take a look. So throughout the whole night, there seems to be maybe something like obstructive sleep apnea. There's some kind of like general sawtoothing to the oximetry signal, kind of present the whole night. But there's these portions. There's this kind of portion in the beginning, and then this portion in the middle where there's kind of a persistent drop in the overall oxygen saturation. Doesn't really return to baseline, and that sawtoothing becomes a little more significant, more profound. So there may be like some hypoventilation, that may be some REM periods, and somebody, hypoventilating on top of obstructive sleep apnea, or it could just be really bad obstructive sleep apnea, getting worse during REM sleep or REM supine, something like that. But they desaturate significantly. There's even that one that looks like, I don't know if that's a spurious signal, but it's like down to 45% near the end of the night. But some pretty profound desaturations down to the 70s a few times throughout the night.
Yes, thank you so much. So absolutely. So this is pretty much a positive saturation waveform for sleep apnea, right? There's nothing that can give you a drop and a resaturation like this other than sleep apnea. Whether it's obstructive or central, we can't tell for sure. It's looking more obstructive here. These are probably REM periods with worsening of obstructive sleep apnea. Yes, you're absolutely right. Sometimes in REM, you can see the whole oxygen saturation baseline is going down, and that can happen if you're having a back-to-back events where there is not enough time for recovery. And that could be just all sleep apnea, or there could be in addition some hypoventilation going on or some desaturation due to cardiopulmonary disease that leading to the whole baseline oxygen saturation to go down. So you cannot tell for sure, but that's absolutely correct. Okay, so this is interesting when I saw it. Someone wants to describe what they see and try to comment from the fellows?
So I see the saturation is below 100, probably around 95% to begin with, the baseline. And it is, it looks like artifact, no. So it is continuously going below 90, about 85%, and coming back throughout the period, throughout the night. So it is fluctuating between 95 and 85, and baseline being 95.
Yeah. Yes.
Mhm.
And anybody else want to add something?
So what do you think it is, though?
It looks very uniform. So it's like Madhuri mentioned, it's pretty much going between 95 and 85, back to 95, back to 85, very uniform. I don't know if maybe this is more of like maybe a central apnea, just given the sort of uniformity, but it's like the entire night. So there's not, doesn't even look like there's, a REM period that's breaking it up or something. So I don't know if some type of maybe central sleep, maybe like a medication induced central sleep, something that seems kind of metabolic in the sense of, very like regular. So that or some hypoventilation, maybe, I'm not sure.
Are you assuming that they're asleep the whole time?
I mean, they may not be, but it looks like it's going down to 85. So if it's somebody who's awake, they're awake hypoxemic, and but I can't really tell because I mean it looks the same the entire night. So I don't see any period where it looks really different at any point.
So but night being, it's from 10:30 to 5 o'clock.
5.
So it's a good sample. And they're on top of Aspen, is that right?
Say the last part again, sorry.
They're in Aspen and they're just watching TV. They're watching, they're binge watching whatever it is of Thrones, right?
Yeah.
How about that? So it pushes you to your limitations on this sort of stuff.
Yeah, so you guys are absolutely right. So this was actually an inpatient overnight pulse oximetry at Metro Health, and the patient had a cardiac has an arrest, and he was pretty much comatose post arrest, and he had an abnormal breathing. And they got this overnight pulse oximetry. So it's a very, very uniform. You can see the drops go down and up to exactly the same level. The whole, perhaps they're sleeping or maybe not. We don't know. I mean, the patient actually doesn't have a normal mental status to know. But that is suggestive of a central or some type of periodic type of breathing, sometimes cyclic periodic, where you do repeat the cycle over and over again. And that usually is a central component. So but I thought it was a pretty interesting waveform. So you can get a lot of information just by looking at the waveform. For example, if you just look at an ODI here, you will miss the whole thing, how uniform it is and how it could be a central component. So the saturation waveform is a very, very important parameter to look at. Okay, now we're going to move on to the oxygen desaturation index and what evidence do we have. So there are a lot of studies, maybe not a lot, but there's enough studies on this documenting that it is a good predictor of AHI. This is one of the studies, this is one of the older ones, 1999, where they did a full PSG and an overnight pulse oximetry. And they looked at the sensitivity and specificity of detecting moderate to severe obstructive sleep apnea, that is AHI of greater or equal to 15. And depending on what cutoff you use, the sensitivity and specificity varies. But in general, of course, if you use a lower cutoff, you're going to be more likely to detect the moderate to severe sleep apnea, but but it is less specific, you may be overdiagnosing. If you use the cutoff of 10, your sensitivity will go down, but specificity increases, and so on and so forth. But overall, in this one, if you have an ODI of greater or equal to 10 on the overnight pulse oximetry, that has a 71% sensitivity and a 90% specificity to detect moderate to severe obstructive sleep, moderate to severe sleep apnea on a PSG. And then if you actually remove those who have cardiopulmonary disease or low FEV1, then your sensitivity stays about the same, but your specificity improves, which means that this is more useful in the population without underlying cardiopulmonary disease, according to the study. This is one of the largest studies that looked at this again, and they had 475 patients that were going for surgery. They were 18 years old or older, and they were going for some type of an operation. And then before their operation, they underwent again a home PSG and a pulse oximetry. And they found a very good correlation between AHI and ODI, and they were able to fit it in a straight line with an equation. And this is the Bland-Altman plot. And just a reminder for the Bland-Altman plot, this is a plot that's commonly used when we're trying to look at the agreement between two different ways of measuring something. And the typical way of doing it is that you plot the average of the two measurements. In this case is AHI and ODI. You plot their average and versus the difference, which is the AHI minus ODI. And then you can tell how the difference changes as the average increases. For example, in this one, we see that at lower average AHI and ODI, there are more measurements in the negative range, which means that the ODI is overestimating the AHI at lower numbers. averages. And then as we go at higher averages, we can see that there are more positive differences, which means that the ODI underestimates the AHI. And we don't really know exactly why this is happening, but this has been also consistent in other studies. But overall,
My name is Michelle calling from University Hospital. I just looked on some of the sites to see if I could get a download on my patient, and I'm not able to do so. Is it possible to request a download for a CPAP report? Oh, what time do they open?
oh,
I only have 5 minutes. All right, thank you.
Sleep grand rounds.
Thanks. Bye.
Okay.
Okay. So if you want to have like a personal call, make sure you're not, we cannot hear you. Okay. So, all right. So, so what did they do? So then they did the table. And this is a little bit busy table, but basically what they did is that they looked at the sensitivity of and specificity, positive predictive value, negative predictive value of detecting an AHI of greater than 5. If you use a cutoff of ODI greater than 5, ODI greater than 10, and ODI greater than 15. And then obviously, if you are using a lower cutoff, you're going to have higher sensitivity but less specificity. And then as you go going with higher ODI, your sensitivity is going to go down, but your specificity is going to improve. And that's how people figure out what's a good cutoff for predicting something, is to try to find the highest accuracy. And for ODI, the highest accuracy for predicting an AHI more than 5 would be ODI more than 5. And AHI more than 15 would be 15 also, and AHI more than 30 would be 30. But if we were thinking of a screening tool, we kind of don't care as much as the highest accuracy as we want a little bit higher sensitivity here. So in that case, an ODI greater than 10 has a sensitivity of about 93% and a specificity about 74% of predicting an AHI of greater than 15. So this is exactly what I just told you, that the cutoff value based on maximal accuracy for ODI to predict AHI more than 5, more than 15, more than 30 is the same. It's more than 5, more than 15, more than 30. But if we want a using it as a screening tool, ODI greater than 10 is a good cutoff to use with 93% sensitivity and 75% specificity to detect moderate to severe sleep disorder breathing. One of the newer studies also that I saw was in 2019, pretty much showed the same. This one difference, it was an automated scoring. So they compared automated scoring of apnea-hypopnea index and oxygen desaturation index. And they also looked at positional obstructive sleep apnea. And again, they had a high agreement, especially for AHI more than 15 in the 90s, and in the 80s, 0.96, 0.89 here for and also if they classify it also by position, they're able to distinguish supine versus non-supine too. So this is another study that they particularly used automated in this one rather than scoring. Some other authors wanted to do some type of a predictive model. So this was published in Chest in 2003, and what they did is they again looked at PSG's results versus overnight pulse oximetry results. They created their own parameter, which is not usually reported on overnight pulse oximetry when we get it from the company. They called it an index. And basically it is the average of the absolute differences of oxygen saturation between successive 12-second intervals. So pretty much it's just another measure of the variability of the oxygen saturation. And then they looked at the accuracy of these indices derived from overnight pulse oximetry in the diagnosis of OSA. And this change index was pretty predictive of OSA. Desaturation index 3%, 2%, 4% were also predictive. They also used cumulative time spent below 90% and 88%. And those were also predictive, not as good as the desaturation index. but also were predictive. And what they did is, these are 10 parameters, they put them all together and created a model whereby you can put the numbers in, and then it gives you a predicted AHI. And then based on that, they found that the predicted AHI correlated really well with the actual AHI. What we thought in our—
Mirna, can we go back over that particular series of 3 slides? So as I understand it, they went 12 seconds by 12 seconds throughout the entire record. They obviously threw out some various things. And they looked at the mean difference in saturation between those 12 seconds and
Right.
got then if a variability index of some sort.
Right.
And so they called it a cumulative differences, which would be if
Yeah,
there was no difference over time, you would have this, and that would be their index. And then they use these other, I mean, some of these are going to be correlated. So they use some sort of model that they put together and they could do that. Huh. It's
Yeah, so
interesting because, you know, you get these black box stuff from things like the Bell and Ring or even even the oximetry data that comes from the portable studies, and they throw together all this stuff. But I've never heard of this before. Okay.
yeah,
Just
that
wanted
was
to be clear.
published in
That
JAST in 2003. So it is a, you know, an important
Right.
study to mention, although this is not something applicable to our interpretation.
Right. But if people are developing something and they want to do that. Now, the other thing here is, while there's a good correlation, that is, if you're 3 and 1, you're 3 and 1, the line tells you it's really good, but the dispersion, which would be the, in a Bland-Altman plot, would mean that if you had a predicted AHI of 3, you might have 3, but you might have nothing. And it's the same sort of thing.
Yes. But you know, they thought it was good enough.
Well, yeah, it's a good R squared, right?
Yeah, good R squared.
Okay.
Yeah. So
Right.
what we were thinking, you know, when I was in my sleep fellowship and I was working with Dr. Stroll about whether this overnight pulse oximetry ability to evaluate for sleep apnea, this applies for special populations. For example, COPD patients, would the ODI still predict sleep apnea on pulse oximetry, for example, in COPD patients? And the population that we looked at specifically was the sickle cell disease patients. And the reason was, it was in a population that it has been found that nocturnal hypoxemia in sickle cell disease is associated with worse clinical outcomes. Whether this is because the hypoxemia itself leads to worse clinical outcomes, or whether it is a marker of underlying cardiopulmonary disease, we don't really know. We just know it's associated with worse clinical outcomes. And also, the oxygen hemoglobin dissociation curve is shifted to the right in sickle cell disease. So it wasn't clear if the ODI will actually still predict AHI in this population. Also, this is a population where there was concern perhaps about hypoxemia leading to sickling and perhaps precipitating sickle cell crisis. It's not clear. Some experts think it's possible. Some experts think it's not true. But this population is more likely to get an overnight pulse oximetry. And the question is, can you kind of tell if there's sleep apnea there or not? And so what we did is we had 45 patients with sickle cell disease who had underwent sleep studies, and we looked at their oximetry data. And we did find a correlation between AHI and 3% ODI in this population. And we did our own Bland-Altman analysis here, and it was kind of pretty similar to the one that we saw, for example, in the general population for the patients going to pre-op. And at lower values, it kind of ranged between, the difference was between -5 and +5. So, but then after that, when the average is higher, things were more dispersed and all over the place. And again, we have a small sample, but compared being able to find, you know, sickle cell disease patients is not easy. So our sample was smaller, but because we're really targeting a very specific population. And this is the ROC curve. And just as a reminder, it's called receiver operator curve. And this is something that people typically use when they're trying to look at sensitivity and specificity. For example, when you come up with a test, how good is this test? And in order to find out, you do something called ROC curve. And basically, this is just an example of what it is. So here you plot the sensitivity on the y-axis and this 1 minus specificity on the x-axis. And a worthless test would, for example, have a line like here, because that means that pretty much the sensitivity and specificity are like flipping a coin. So it's really a worthless test. Now, the more you go towards the corner here, which is representing with 100% sensitivity and zero for the x-axis, which is 1 minus specificity, so that would be 1 specificity. So the more it is to the corner, the better is the test. And what do they calculate is something called area under the curve for the ROC curve. And so you calculate the area. So the more it is towards the corner, the bigger the area is going to be and the better the test that you have. So pretty much every single study that looked at accuracy of a test uses this ROC curve. And so when we looked at the ROC curve in this small sample, it was a relatively good curve. The area under the curve was 0.8. So in general, 0.5 is when it's really useless. 0.7 to 0.8 is acceptable. 0.8 to 0.9 is excellent. And more than 0.9 is really outstanding. What we did here is also we divided the sample into those who had what we thought was a normal saturation, mean saturation, which is greater than 93%, and those who had a low mean saturation, less or equal to 93%. And the highest accuracy was with 3% ODI cutoff of 6 or more for those with the normal mean saturation, whereas the highest accuracy for 3% ODI cutoff was 11 or more for those with low mean saturation. So basically, the ODI is going to overestimate the AHI in the patients with low mean saturation. And we are not surprised based on the oxyhemoglobin dissociation curve shape. So we know if we're at the PO2 of 100, for example, and we have a saturation that's 99, 98%, this is a relatively flat line. So you really have to drop your PO2 by a lot to drop your oxygen saturation. Whereas if you're starting with a lower saturation, say here a PO2 of 60, which corresponds to saturation of 90, it's called like a slippery slope. And then you're gonna have a relatively smaller absolute difference of PaO2 leading to the same drop in oxygen saturation. So basically for those with a low mean saturation, any small flow changes can lead to a drop in saturation because it leads to a changes in the PO2 on this slippery slope here, area of the oxygen desaturation curve. So that's why when we're talking about the cutoff of 10, for example, it is mostly for patients who have a normal mean saturation. For patients who have a lower mean saturation, the cutoff might need to be higher. Otherwise, you'll be overdiagnosing sleep apnea using ODI. What I wanted to also talk about is that in this particular population, the ODI correlated really well with AHI. However, we did not find any correlation with AHI in any of the parameters, the other parameters, mean saturation, percent sleep with saturation less than 90%, nadir saturation. All of these did not correlate at all with AHI. And compared to, for example, this previous study here where they had some correlation. And that is because our population had a high burden of cardiopulmonary disease. So basically, there were a lot of patients who just had hypoxemia. So their mean saturation was low. They spent a lot of time with saturation less than 90%. Their nadir was low, but that's not because they had sleep apnea. They did not have any sleep apnea. So that's important to recognize when you're reading studies and they talk about oxygenation. For example, cumulative time, there were some studies talking about cumulative time spent less than 90% is associated with worse prognosis in patients with sleep apnea. However, this might be related to something else other than sleep apnea if these patients have underlying cardiopulmonary disease. So it's important to differentiate between these two things. One interesting thing is that actually we did look at the waveform in the sickle cell disease project that we did. And there were 2 raters from our department, very experienced raters. We gave them the saturation waveform and we asked them to predict what's the patient's AHI, what is the likelihood of having sleep apnea. And the ROC-AUC for positive or indeterminate saturation was only 0.61 for the first rater, and it was 0.7 for the second rater. And there was actually the variability was pretty high. The reliability, the kappa statistic for reliability was only 0.28. So basically the waveform did not really help as much in predicting sleep apnea in this population. It was the ODI that was more helpful. In chronic heart failure, there are also a study that showed very, very similar finding. It's amazing how similar it is. In this study that they also looked again at ODI and AHI, in particular chronic heart failure patients. So some of those may have central component. They found a cutoff of 12.5 desaturation events per hour was also associated with 93% sensitivity, 73% specificity for detecting an AHI greater or equal to 15. So it's also studied in chronic heart failure patients. In this particular study, they used a very low frequency increment of heart rate variability to see if that detects sleep disordered breathing. They did not find it a significant parameter. I know other studies have shown that heart rate variability can help in detecting sleep apnea, but not in this particular study. Okay, so those are examples. This is just, I want to point out, it's important to look at artifact. For example, this is an example of overnight pulse oximetry where there's a lot of breaks here. So this is really not a good pulse oximetry and you can't really tell or interpret it. You're going to say it's low quality and perhaps repeat. So look at the breaks here for artifact. I'm going to talk a little bit about what can overnight pulse oximetry help us in other than sleep apnea? What does it show us other than sleep apnea? So it's been looked at in cardiopulmonary diseases, COPD, congestive heart failure, neuromuscular disease, pulmonary hypertension patients. In general, the worse disease you have, the more nocturnal oxygen desaturation you have, which just makes perfect sense. For example, COPD patients, there are mechanisms why COPD patients desaturate at night. First, they have decreased in-minute ventilation during sleep, which happens in all of us. Normal subjects have that, but because they have poor reserve, they tend to drop their oxygen saturation. There is irregular breathing during REM sleep, rapid shallow breathing, which leads to increase in the physiologic dead space. During REM sleep, we have decreased activity of intercostal muscles, and COPD patients depend on those for ventilation. There is some evidence that during sleep, there is also increase in resistance, airway resistance, upper and lower. There is absence of cough reflex, and so there is some more mucus plugging and perhaps increase in VQ mismatch due to retained mucus in small airways. And there is resetting of the respiratory control to higher PCO2 and lower PO2 during sleep. And this is an example of a patient who did not have any sleep apnea and just desaturated here. That thought was due to be COPD, patient had COPD. And also here you can see a desaturation here. Those are, we call them as sustained desaturations due to cardiopulmonary disease versus episodic desaturation due to sleep apnea. A little bit about oxygen therapy. So everybody knows, the Medicare criteria for oxygen therapy, but I think that it's important to know that this criteria came from a very basic observational study, not a lot of evidence to support it. For example, this is one of the landmark studies, an old study, 1992, where they looked at nocturnal desaturation and mortality in patients with COPD. They defined nocturnal desaturation as one of the two definitions. The first one is that you drop for 5 minutes or more below 90% and reach at least 85% at least one time during sleep. And the second definition was desaturation 30% or more of time in bed spent below 90%. And they found worse mortality, reduced survival in those who desaturated for 5 minutes or more to a nadir of 85. And this was statistically significant here. The other definition, they did not find a statistically significant difference. And based on some observational data, the medical criteria call for oxygen therapy at night if you desaturate for 5 minutes or more for 88% or less. Now, this is a landmark study that was done in 2016, and it was published in the New England Journal of Medicine. And it's a randomized trial of long-term oxygen for COPD with moderate desaturation. So we all know the old trials of LTOT finding improved survival in COPD patients if they have resting hypoxemia with a PaO2 less than 55. But the question was, if they have moderate hypoxemia, for example, if the saturation is between 89% to 93%, does oxygen therapy help? How about those who desaturate with exertion and then those who desaturate at night? Does actually oxygen therapy change mortality? Remember, all what we have is observational data showing there is increased mortality in those who desaturate, but that does not translate that if you give them oxygen, they actually improves outcomes. So this study was trying to answer that question. And so what they looked at COPD patients with moderate exercise-induced desaturation and during a 6-minute walk, where they had to desaturate, but not to, but stay above 80%, yes, I'm sorry. But they have to go down less than 90% for at least 10 seconds or more. And they will randomly assigned to receive long-term oxygen versus no oxygen. And those who desaturated with exertion, and you're going to say, why is this relevant to us? You know, we're sleep doctors. Those who desaturated with exertion, they gave them oxygen with exertion, but also with sleep, thinking that if they desaturate with exertion, they probably desaturate with sleep. And then they looked at outcomes and they followed them up actually for 6 years. And they did not find any difference in outcomes, whether it was hospitalization or mortality. The two curves looked exactly the same. So, we still give oxygen for patients who desaturate with exertion, and we still give them oxygen at night when they desaturate. This did not change the medical criteria for oxygen therapy, but it does give us an idea that, perhaps giving them oxygen is not changing much. So for me in my clinical practice, if a patient, for example, really, I do have some younger active patients who have a very active lifestyle and they just cannot use their oxygen with exertion, for example, then, I am not too worried about them because I don't really have evidence that it's going to affect their outcomes, at least for the next 6 years. This does not apply to patients who actually feel better with oxygen therapy. They excluded those. There are some patients, they say they feel better when you give them oxygen. This does not apply to patients who are hospitalized, for example, with COPD exacerbation and being discharged on oxygen. So those are stable COPD patients. So we don't know if they've been decompensated in the hospital, whether this will be different. But it does raise a question whether all this oxygen prescription that we give, whether it's really changing anything.
Yeah, Mirna, the VA has now started to use that criteria.
Oh.
And withholds oxygen from those people who desaturate with exercise or only desaturate at night.
Oh, okay.
And it's causing a lot of heartburn. I'm a director of oxygen therapy, and all the pulmonary guys are telling me I'm, terrible. And we just sent them this article and say, "What's your argument?"
Yeah. Especially for those, I mean, right now, even some people in the VA, we don't give oxygen for people who smoke, but outside the VA, we do.
Now that
And
just
it's a
changed
risk.
because they feel as though smoking is a personal right. We just
Right.
had 2 more people burn themselves with smoking and oxygen.
Yeah, so you wonder, they're not really beneficial. There's risk of burns. So, for those who smoke, definitely oxygen, it's very, very reasonable to withhold oxygen with exertion, I think.
Yeah, it's really good though to fire up your charcoal briquettes in your grill.
All right, so this is medical criteria for oxygen therapy. I'm going to skip through that because I know most of you guys know it. I'm going to talk about variations in physician interpretation of overnight pulse oximetry. So this was a study that was done actually at university hospitals by Dr. Stroll and Rory Ramsey that looked at interpretation of overnight pulse oximetry. So unlike portable, PSGs, home sleep studies, overnight pulse oximetry has no guidelines for interpretation. ASM does not tell you how to interpret an overnight pulse oximetry. There's no, and that leads to people interpreting them differently. And that's what Dr. Stroll and Ramsey, Dr. Ramsey found. They gave 41 physicians 3 studies, and they asked them to interpret them. And they had 50%, for example, on the study recommending PSG. They have, for example, 30% recommending oxygen. So they had a huge variation in recommendation and how they interpreted it. And that is not a surprise, given that there's really no guidelines on how do you interpret it. So what we wanted to do is we wanted to try to get like a template where physicians who are learning, pulmonary physicians or sleep physicians who are learning how to interpret it, to use as a guideline. And this is the template that we used in a study. And first you have to look at the duration and the artifact to make sure that the study is adequate. Second thing is looking at the mean oxygen nocturnal saturation. And that is primarily, the mean primarily looks at possible underlying cardiopulmonary disease. Now, if you have very, very severe sleep apnea, your mean can go a little bit down, but mostly the mean, if you have a low mean, you have to think about underlying cardiopulmonary disease or hypoventilation. And then the ODI is based on the literature review that I just shared with you. We came up with this template, how to read the ODI. And then the waveform. So we had clear distinction between 2 things, which is the sleep apnea waveform pattern and other disorders waveform pattern. So there are 2 things that you can have the, what we call as a sawtooth, but you don't really see the sawtooth on the overnight pulse oximetry because it's kind of squished. But this is the ups and downs, there are episodic desaturation, and a lot of times with immediate resaturation, and you can have it as a positive or intermediate or negative. And then whether there are some sustained desaturations that are slow and sustained that are suggestive of cardiopulmonary disease. So need to note that in your overnight pulse oximetry. And then the time spent less than 88, with saturation less than 88%, less or equal to 88% in minutes, and based on Medicare criteria. But also it's important to know that Medicare wants you to correct any reversible cause before you give oxygen. So if you think that the patient has sleep apnea, you kind of need to treat sleep apnea first before you give the patient oxygen. They actually want the patients to be seen, for example, in stable conditions and things like that, because they don't want chronic oxygen therapy for potentially reversible causes. So it's important to note that. So with this template, we asked 4 pulmonary critical care fellows to use that template, and these fellows had no prior experience at all with any interpretation of overnight pulse oximetry. We gave them that template, and we asked them to interpret 50 overnight pulse oximetries based on that template. And then we kind of divided the suspicion for sleep apnea from the template depending on the ODI and the waveform. For example, if your waveform is positive or indeterminate and your ODI is greater or equal to 10, then that's considered a high suspicion for sleep apnea. And if your ODI is less than 10 and your waveform is completely negative, then that's a low, score 0 suspicion for sleep apnea. And then the other ones are in the middle. And there was a very good agreement for score 3 and score 0. With the kappa 0.9 and good here 0.7, but in the middle there was a little bit of variability. So which makes sense, right? Because most of the people will agree this is positive for sleep apnea and oh, this is negative. But when it's in the middle, when people will be, well, we don't know. So that made sense. And when we looked at the specificity, at the sensitivity and specificity, so depending on what do you want from the overnight pulse oximetry, you can decide what to use as cutoff, right? If you want to use it as a screening tool, then you may say anything score 1 or above, I'm going to refer for PSG. So only those with ODI less than 10 and negative waveform, I'm going to hold off on PSG, but the other ones I'm going. In that case, the sensitivity will be high. If you want to say only who they really show OSA, I'm going to send them, then you can use a higher score. So depending on here we have the different sensitivity and specificity for different scores, depending really what do you want to get out of the overnight pulse oximetry. But in general, the sensitivity and specificities were pretty good using that scoring method. So just important points for the overnight pulse oximetry. Overnight pulse oximetry cannot exclude OSA, especially in a patient with symptoms. So everything I talked about here applies for either if there's a population that you want to screen for sleep apnea, pre-op population, for example, patients with atrial fibrillation, that it's not feasible to do PSGs in all of them, then you can use the overnight pulse oximetry. However, if you have a symptomatic patient, you're going to proceed to PSG no matter what the pulse oximetry shows you. However, if the patient was in the hospital, for example, and you cannot get a sleep study and you want to comment something about the likelihood of this person having a sleep study, you can get an overnight pulse oximetry, for example. But you can never stop at overnight pulse oximetry in a symptomatic patient who reports sleep symptoms. But I think it applies the same for a home sleep study, right? When it's negative and the patient is symptomatic, we still do a full PSG. So it's similar in that way. The waveform and the ODI are the important things to look at if we're looking at diagnosis of sleep apnea from the OPO. I'm just going to mention a little bit about, for example, other portable monitors. The apnea link, for example, we use the apnea link at Metro Health. It is also a type 4 monitor because it has 3 channels. So the minimum for A3 at level 3 is 4 channels. So this is a type 4. And for example, this is a validation study that was published in the Journal of Clinical Sleep Medicine for apnea link in a population of morbidly obese patients. And these patients underwent 2 successive nights of recordings. The first was with apnea link 1 and the following night with both the Embellata, which is the home sleep study, and the apnea link AL2. And as you see here, their sensitivities and specificities are also very similar. Sensitivities in the 90s to 80s, specificity depending on the cutoff, but pretty similar to what we see with the overnight pulse oximetry. And this is, again, the correlation, which is pretty good. And this is their bland Altman. So it has a very similar appearance. This is also to look at diagnostic accuracy of level 3 portable sleep studies versus level 1. So the question comes here is, what about the portable sleep studies level 3? How do those compare with the PhD? And I think Dr. Stroll wanted to also touch on that. So I was just going to touch on that. And that is, this is a meta-analysis that was done, and they looked at 59 studies with a total of 5,026 patients. And there's some variation in the studies, but overall there was good homogeneity among the studies. And they found the AUC, the area under the curve for the ROC, of between 0.99 to 0.85 across different levels of disease severity. But again, those was in population with high suspicion for sleep apnea and with uncomplicated sleep apnea, not complex sleep apnea, and mostly comorbidities were pretty simple and not complicated comorbidities also. So the level 3 has a higher accuracy, obviously, compared to the level 4, which is expected. And I'm gonna stop here. And this is my class. These are my co-fellows, Hovig, Joyuthi, and Laura. And this is our picture with our mentors at that time, which you guys also know. So thank you so much. And if you have any questions, I'll be happy to answer your questions.
Terrific. So really, the bring up portable is that you mentioned that we get trained in how to interpret portable studies. I think we are trained and have a manual to identify what events are, but the recommendations and the interpretation of the values are not standardized. Certainly not for oxygen saturation in the HSTs. So it would be fun I'm trying to get together some sort of website or some sort of process to look at the concordance of interpretation of HSTs among fellows and attendings in our system, and get Mirna involved because she knows the design of those things and the analysis and all that. She'll be our objective outside person.
Sure. Yeah.
So that was a great talk. I have a real quick question for you. So sometimes we see people have severe sleep apnea. They drop their O2 sat, to 70%, and you put them on CPAP, and you get their compliance report, and they're doing fine. Is there any value to get, after they've been on CPAP for a while, to get, a nocturnal pulse oximetry test, and then if they have low O2, do we put them on supplemental oxygen? I mean, I just wonder, is there a cutoff to say, hey, your oxygen is saturation? I saw somebody yesterday, they desat it down to 60. I'm like, well, just because I put you on CPAP doesn't mean that your O2 is going to come back to normal. So is there any value to doing that at all?
Yeah, that's a great question. So there's not a lot of studies looking at overnight pulse oximetry on CPAP. That's actually a good research area. We do it a lot, for example, at Metro Health in my institution. When we read sleep studies, usually when we have baseline hypoxemia or we feel there's some hypoxemia going on that's out of proportion of the sleep apnea, I always recommend to get an overnight pulse oximetry. But if we feel that the sleep apnea is the reason for the oxygen desaturation, there's usually no need to get an overnight pulse oximetry, because if you're able to stop the events from happening, your oxygen saturation should be good. So I usually only do it if I feel patient has underlying baseline hypoxemia that may not respond to CPAP and may need additional oxygen therapy. But if I feel that all the desaturations are due to sleep apnea, I usually don't get one, but I would like to get Dr. Stroll's opinion also about that.
Well, we, you know, I do that to sort of check what they're doing on their machines. Now, what to do about it? I mean, 2 liters of oxygen with a flow of 35 liters a minute through your CPAP machine doesn't change your FiO2 very much. So the fact that it does anything is really sort of amazing. So I think the reason is just to identify what their underlying condition gives them for their hypoxemia. And now, obviously, if one of the reasons for the hypoxemia is that they have a high CO2, you can put them on non-invasive ventilation. And if they're using CPAP and they like it, they like the nasal mask or the full face mask, that they usually adapt to a bi-level pretty well. And really, the bi-level is preventing them from getting worse at night, not necessarily curing whatever they have.
Mirna,
That's my thinking, at least, John.
can you get, this is Dennis, can you guys hear me?
Yep.
Yeah, so I'd just add one comment on that. I've actually taken a little bit of a different approach. So patients that are really bad with their desaturations, I often do get an oximetry as part of the follow-up with the download. Because the assumption is we always assume that the downloads are accurate, and if their HI is low, that it can't be wrong. But I've got a small case series of patients where, you know, I have downloads and compliance data on the same night, and the oximetry is discordant with the download. The download suggested the sleep apnea is under good control, but they're actually still having uncontrolled sleep apnea. It's not that they have persistent hypoxemia related to some other condition. It's that their OSA still is actually not as well controlled as we'd think from the download. So if they're really hypoxic, I often do that as just part of my standard to verify that it's sort of a double check. And most of the time it's okay, but there are some patients where I've caught where it's not okay and they have to undergo a reassessment of their pressure setting.
That'd be a nice data set to start to get together, because then when we have our one-year fellows to do a research project, they could look at that data set.
Yeah.
Do you think we need IRB on that? Probably.
Yeah.
Good.
Mirna, there's a question from Dr. Pinto. Hi, by the way. Good to see you. Can you please comment on the positive predictive value and sensitivity? It's in the chat. If you open it up, you can see it for screening for OSA in patients without comorbidities, basically. And by the way, Dr. Pinto is one of the dentists. Well, you probably remember him that works with us. Hi, Andres. How are you? Good to see you.
Oh, can you please comment on OPO positive predictive value versus sensitivity for screening for SA in patients without comorbidities? Thank you for the talk. I think you might be considering the prevalence. I don't know if he wants to ask about, of course, the difference between sensitivity and positive predictive value is if the prevalence of disease in the population. So a test can be sensitive, but you know, if the prevalence is low, the positive predictive value is not going to be good. So obviously the population, it's important to be done on the right population. So when we're screening for obstructive sleep apnea, we are not screening general population, 20-year-old females or something like this. We are mostly screening people that they are at increased risk of OSA. So with a high sensitivity, you're expected to have a good positive predictive value. Now, without comorbidities, I'm not sure, is that what the question is about?
Yeah, I guess you stated that it's a decent screening tool for patients without comorbid disease based on the samples you get, the sickle and the cardiovascular patients. I was just wondering if that population could be more of a predictive value, or is it?
Yes.
You had a higher level of ODI that you needed to get sweet spot.
Mm-hmm.
Your ODI had to be 10 or more.
Right. Okay.
Right. So you think that you think you're asking if it's better for patients with more comorbidities or less comorbidities?
Less.
So less, that means that he's interested in if people walk into a dental clinic and say, do I have sleep apnea or what do I want to do? Could oximetry be one of the things to do? There are two parts of that
Yeah.
question. First is getting the oximeter, and third, you can't get paid for it. So
I would think about it a little bit is if a patient is a good candidate for a portable home oxygen, portable home sleep study, probably overnight pulse oximetry is going to be helpful. If the patient is not a good candidate, probably the overnight pulse oximetry is not going to show much, because remember, in home sleep studies, we're scoring based on desaturation anyways. So, so if you have the, older, the men, obese men, they desaturate usually, and you can catch OSA in those patients. If you have a younger female with normal saturation, you're probably not going to catch any OSA.
Thank you.
Dr. Ayache, I have one quick question. Thank you for the talk. I saw a patient in pediatric clinic last month who was referred for sleep apnea after she underwent a cholecystectomy and then had some difficulty being extubated post-op. And they did an overnight pulse oximetry and a transcutaneous CO2 overnight. And I guess I was wondering, is that something that's been looked at in adults? I mean, adding I know it's a little more technically complicated, I think, than a overnight pulse oximetry, but has that been looked at in addition to getting, O2 and CO2 overnight as part of like a combination kind of study? I don't know.
So, as you know, TCO2 monitoring is a little bit harder in adults. It's more done in pediatrics, right? Every pediatric sleep study you do TCO2 with it, and it's not the same in adults. It's a lot of sometimes it needs a lot of calibration because of the skin barrier. If their patient is obese, it's not as easy, I would say, in adults as in pediatrics, but this can be done. It would be a good idea to do it for inpatient, like if we have an inpatient overnight pulse oximetry, to add transcutaneous CO2 to that. I have not seen that, but I think that would be something to do and look at.
Okay, thank you.
Sure.
good. Well, thank you. We're going to move on.